2016, there'll be about 134,000 new cases of colorectal cancer diagnosed in the US and about 50,000 deaths. And of these, about 14,000 cases and 3,300 deaths will occur in people younger than 50. In the literature, early onset disease is often defined as cases occurring under 40, but in this presentation, I'm going to focus on the under 50 age group to include all cases occurring outside of screening age for average risk. Overall, colorectal cancer is the third most commonly diagnosed cancer, and it's the third leading cause of cancer death in both men and women. And it's also the third leading cause of cancer death in women younger than 50. However, among men younger than 50, it's the second leading cause of cancer death and the most commonly diagnosed cancer. It falls to the fourth most common cancer in young women because of the large numbers of breast and thyroid cancer diagnosed in this age group. Malignancies can develop anywhere within the colorectum, which is divided into three sections for the purposes of describing cancer surveillance data. The proximal colon extends from the cecum to the splenic flexure. The distal colon includes the descending and sigmoid colon and the rectum. And the distal colon and rectum are often combined and referred to as the left-sided colon and the proximal colon as the right side. This slide shows tumor subsite distribution by sex for young patients on the left and older patients on the right. Older patients are much more likely to be diagnosed with tumors in the proximal colon, particularly women, among whom about half of colorectal cancers are in the proximal colon. In contrast, younger patients are more likely to be diagnosed with rectal tumors, particularly men. And the sex differences by subsite are much smaller for younger patients. Right and left-sided tumors differ not only in their distribution by sex and age, but also in their biology, in their response to therapy, and patient outcomes, which is causing speculation that these tumors may have somewhat different carcinogenic pathways. And this may also be true for early versus later onset disease. Here we have the racial distribution for young patients in blue and older patients in red. Young patients are much less likely to be white, 66% versus 77% of older patients. And they're much more likely to be Black, Hispanic, Asian, or other minority group. This figure shows age-specific incidence rates by sex. For the older age groups, men are about 30% more likely to develop colorectal cancer than women, but for younger age groups, risk is pretty much the same by sex. And you can see here why colorectal cancer is often referred to as a disease of older people. 9 out of 10 cases occur in people older than 50. This slide shows incidence trends for all ages combined overall for colorectal cancer in blue and for colon and rectal cancers separately in red and green. Incidence rates for colon cancer were increasing until the mid-80s, but since have been declining fairly rapidly by about 3% per year over the last decade. And similarly, rectal cancer rates were stable until the mid-80s, but have since been declining, albeit a little more slowly, by about 2% per year over the last decade. And these declines are attributed to changing patterns in risk factors as well as the uptake of screening. But of course, because these reflect the 89% of patients that are diagnosed over 50, the patterns in young adults are completely masked. Back in 1998, there was a small study out of LSU Medical Center reporting on early onset patients, and they suggested that there was possibly an increase in the disease at their institution. Then 5 years later, O'Connell and colleagues published an analysis of SEER data that contained more than 5,000 patients under age 40 again, and they reported increasing incidence rates. But for some reason, this study doesn't seem to have garnered much attention. We didn't realize the trend for several more years in 2008 when we were updating an educational publication on colorectal cancer. And it led us to extend O'Connell's analysis of SEER data. We included all patients under age 50, and we confirmed the increase and found that it was continuing. And I show this slide just to illustrate how delayed this information was in being disseminated. And what we thought at the time was an emerging trend, but you'll see in a few slides that it's really not an emerging trend. It's been around for a while. So the next few slides show incidence rates for early onset disease from 1975 to 2012, which is the most recent year for which we have data. Here I have incidence trends for the older group on the left for a comparison, and you can see that it's pretty interesting. The trends are exactly the opposite. Rates were declining fairly rapidly in young adults until the mid-90s, and then they did a turnaround and since have been increasing by about 2% per year. So in less than 2 decades, there's been more than a 50% increase in incidence rates. And I do want to point out that the axes are different here, so obviously the burden is much lower in the younger age group, but in order to illustrate the trend, I shortened the y-axis. So this increase is driven by the most common histologic subtype, which is non-mucinous adenocarcinoma. It accounts for about 90% of cases in this age group. And although there's a larger proportion of familial cases in the younger age group, we think it's sporadic cases that's driving the increase because hereditary risk wouldn't change this rapidly. So as you'll notice, I'll point out the trends here by sex are very similar. So for the remaining incidence trends, I've combined the sexes so that we can stratify by different variables. Here we have incidence trends by tumor subsite, and it becomes clear that the increase is confined to the left-sided colon. Incidence rates for proximal tumors, which are shown in blue, have been stable during this time period, whereas rates of distal colon cancer were declining by about 2% per year until the mid-90s, but since have been increasing by that same magnitude. And the trend for rectal cancer is more striking. Rates were stable until the early 90s, but since have been increasing by almost 3% per year. So the result is an almost doubling in the incidence rates over the past 2 decades, from 2.6 per 100,000 in 1991 to 4.8 in 2012. So whereas in the mid-70s and 80s, tumors were equally distributed within the colorectum among young patients, now they're much more likely to be diagnosed with rectal tumors, which we saw in the earlier slide. Because of the opposing trends by age, a much larger proportion of colorectal cancer patients are younger than 50. The proportion has increased from 7% in 1990 to 11% in 2012, and it's even larger for rectal cancers. In 2012, 14% of rectal cancers were in patients younger than 50. And this is not because of changes in the overall population distribution, because in fact, this age group is a smaller proportion of the population now than it was in 1990. It's gone from 64% to 55%. Here we have trends by stage at diagnosis for colon cancer on the left and rectal cancer on the right. There have been increases for every stage of diagnosis, with the largest increases for distant stage disease. Distant stage colon cancer has been increasing by 3% per year, and distant stage rectal cancer by 3.6% per year. And these are, just to point out, if you're not familiar with surveillance data, these are large increases. Rates don't usually change this rapidly. Because the patterns have been fairly similar by stage distribution in younger patients has not changed much, particularly for rectal cancer. And you can notice here that rectal cancer is diagnosed more often at a localized stage than colon cancer. It's about 38% to 33%, and that's probably because of the earlier presence of symptoms for rectal cancer. These figures show incidence trends for 4 broad racial and ethnic groups from 1992 to 2012. We can't look at these data before 92 because that's the year that cancer registries began collecting data on Hispanic ethnicity. But it's pretty clear here that the largest increase has been in whites, and this table shows the annual percent change during this entire time period for each of these groups. And it's interesting to note that risk in young Asians and Blacks has not really changed that much. So as a result of that, whereas in the mid-90s, the highest rates of rectal cancer were in Asians and Blacks, today the highest rates are in whites. The next few slides show incidence trends by age. Here we have 10-year age groups under age 50. Rates are increasing for every age group, with the largest magnitude being in the youngest group, 20 to 29. And it's hard to have an appreciation for this 4%, almost 4% increase annually for this age group. But if you blow this up, you can see how extreme the slope is. Rates in this age group have doubled from 1 per 100,000 to 2 per 100,000. But still very small. It's important to realize that this age group only represents about 6% of cases under 50, with 20% of cases in their 30s and about 3/4 in their 40s. Another thing I'd like to point out in this slide is the timing of these increases. You'll notice they're different. For people under 40, the increase began in the late 80s, whereas for the 40 to 49-year age group, you don't see it for several years later. And that's typical. Usually, changes in trends will first occur in the youngest age groups. They're a bellwether for the burden to come. So this figure shows the timing and magnitude of the trend for each of these 10-year age groups for colon cancer in blue and rectal cancer in green. And here you can see that for people younger than 40, rectal cancer incidence rates have actually been increasing for almost 4 decades by about 3% per year. And you can also see that colon cancer incidence rates began increasing earlier in the 20 to 29-year age group and are increasing at the same rate as rectal cancer. Because the trends by age differ, we were interested in looking at smaller age groups. This slide shows incidence trends for 5-year age groups from 20 to 64. And I know this is a lot to look at, but if I can get you to focus on the earliest time period in the left of the figure, you can see that basically with age, risk increases at a fairly similar increment, right? So the lines are fairly evenly spaced. This is what you expect. But if you look at the right side of the figure, with the current rates, you see something strange happening for people 50 to 59. And it's because you have opposing trends here. Rates are increasing in the 50 to 54 age group, but decreasing in 55 to 59. And so rates are converging in these groups. This is very unusual. So here they are broken out for colon cancer on the left and rectal cancer on the right, and you can see that, in fact, for rectal cancer, rates have converged. So in the mid-70s, rates of rectal cancer were 80% higher in people 55 to 59, but today they're the same. And the same pattern is occurring for colon cancer, but it's less striking. So these differences by age were the catalyst for a new analysis that we're doing, and I'd like to ask you to keep this under your hat. This is a project we're working on right now, and we're hoping to publish this year. But it's an age period cohort analysis of colorectal cancer in the United States. And that type of analysis tries to disentangle period effects from cohort effects. And a period effect is something that happens, it's an exposure in time that affects all age groups. So an example would be radiation exposure after a nuclear bomb. It affects everyone, all ages, during a particular time point. A cohort effect is an exposure that affects particular generations. So an example would be the children of women who were treated with DES during the 50s and 60s before we knew that it was carcinogenic. So what we found, and these are just early results, but this is from the cohort analysis, and these are rate ratios. People born in the early 40s have the lowest risk of colorectal cancer. Previous generations, risk in previous generations was decreasing incrementally. But since that birth cohort, successive generations have had increasing risk. And the result is that for people born in 1988, they have 3 times the risk of colon cancer and 4 times the risk of rectal cancer compared to people born in the early 40s who have the lowest risk. This slide shows self-reported screening, colorectal cancer screening prevalence for 2005, 2010, and 2013 by 5-year age group. And I show this just to illustrate the delayed initiation of screening for people in their early 50s compared to people in their late 50s. So this helps explain the differences in the incidence patterns. These maps show geographic variation for colorectal cancer incidence rates for young patients on the left and older patients on the right. The patterns are similar, with the lowest rates in western states and the highest rates in the South and the Midwest. But it is interesting that the state variation is larger for young patients. There's a 70% difference in risk in the highest versus the lowest risk states for young patients, and for older patients, it's only about 55% difference. So now we're going to move away from incidence. The next couple of slides are showing stage at diagnosis and survival. Here we have stage at diagnosis for young patients in blue and older patients in red. Only 33% of patients under 50 are diagnosed at a localized stage compared to 40% of older patients. And this is because of the delayed diagnosis for younger patients, but it may also reflect insurance status, because people under 50 are 3 times more likely to be uninsured than those over 50. And people who are uninsured are diagnosed at a later stage. Hopefully, as more young people obtain coverage with the Affordable Care Act, we'll see a stage shift for the young patients. This is 5-year relative survival over time for young patients on the left, and by stage at diagnosis and age on the right. The good news is that survival rates are increasing from 56% in the mid-70s to 68% for the most current time period, which is a bit higher than the 65% survival that we see for patients who are over 50. And this is true for every stage at diagnosis. Younger patients have higher survival, despite more aggressive tumor characteristics in general. And this is probably reflecting more aggressive treatments in younger patients, as well as fewer comorbidities, and also a preponderance of left-sided tumors, because left-sided tumors have higher survival rates. Despite the improving survival, we think there may be an increase in colorectal cancer death rates in people younger than 50, although we really do need more years of data to establish this trend. On the left is observed death rates, and on the right is output from joint point analysis, which is a tool that we use to quantify the magnitude and timing of trends. And you'll see that death rates were declining until the late 90s and then flattened out, and since 2004 have been increasing by about 1% per year. And this is, of course, in sharp contrast to the rapid declines in people over 50. Strategies for reducing colorectal cancer risk at every age include maintaining a healthy body weight throughout life, being regularly physically active, consuming a diet high in plant-based foods and whole grains, limiting alcohol consumption, consuming recommended levels of calcium, preferably through food sources, and not smoking. And of course, screening reduces risk of colorectal cancer, and many people don't realize that screening is appropriate under age 50 for many people. These are defined in two broad groupings: those who are at high risk because of a genetic predisposition for the disease, and those who are at increased risk because of their medical history. People with a first-degree relative, which is a parent, sibling, or child who's been diagnosed with colorectal cancer or even adenomas should begin screening in their 40s. And it's clear that a lot of people don't realize this. There was a study that was published last year of relatives of colorectal cancer survivors, and they found that and all of these people should have been screened. It was 40 and older, and only half of the group under 50 had been screened. It was double in people over 50. So here's a barrier that we need to overcome. In conclusion, colorectal cancer incidence rates are continuing to increase, particularly rapidly for rectal cancer. And although we don't know what's causing this trend, there are important things that we can do to make a difference. And really, it's all about education, educating people and physicians on early screening when it's appropriate, because physicians are the conduit for screening in their patients, and also increasing awareness in the general public as well as with primary care doctors, so that we can facilitate earlier detection, knowing the symptoms, and of course, etiologic research. These are ecologic data that I've shown you. They show what the problem is, but they can't solve it. They can't tell us what the cause is. So there's a desperate need for etiologic research on early onset disease. Thank you.